Hello, good day everyone. This topic is all about the advanced nutritional biochemistry of nutrients. Specifically, these are the topics that either were not discussed at all or uh, uh, were not clear no, in the during the reporting. These topics are also very important to emphasize, thus they are included in this discussion. First, let's deal with those topics under the carbohydrates. So I only have one topic that I'd like to emphasize, and I think this was not brought up during the reporting, and this is all about resistant starch. So, you know that resistant starch is a type of fiber, so therefore, the physiological benefits that are linked with fiber are also linked with resistant starch. So there are actually like classifications, no, for resistant starch. So we have five classifications or five types of starch. First we have RS1 or resistant starch 1 or resistant starch type 1. So you can call it simply as RS1. So the main characteristic of RS1 is that it is physically inaccessible type of starch. That means the starch cannot be accessed by the enzymes because they are located um, in a compartment of the cell that is physically inaccessible by enzymes. Okay, so by the way, your starch, resistant starch is just like the other types of starch, it is composed of glucose units. But the thing is, the enzymes cannot break this down. So that's why they are this type of starch is considered resistant. Okay. So it's not like cellulose that it has beta linkages. So resistant starch has actually alpha alpha glycosidic bonds, but again, the thing that makes it resistant is because due to these characteristics, they are incapable of being broken down by human enzymes when consumed. So that's why they are called as resistant starch. So for RS1, again, this starch is physically inaccessible due to its location in a certain compartment of the plant cells. Okay, so examples of RS1, okay, um, are those products that are made from coarsely ground or whole grains like bread, seeds, and legumes. So usually RS1 is found in these sources. Okay, so physically inaccessible due to cell wall barrier. Okay, even chewing or digesting them cannot release this physically inaccessible starch. Okay. Next is RS2. So RS2 is crude starch, which due to its structure is not digested. So due to its crystalline form, it's chemically the same with starch, but its conformation is in this form that is not accessible now by the enzymes. So its occurrence is found in raw potatoes, green bananas, high amylose corn. Okay, next is RS3. RS3 is formed after cooling the gelatinized starch. You remember what you have discussed from basic foods, no? 'Di ba, when you heat water and starch mixture, such as when you cook rice, kung maglungag mo, the process uh, that we can observe no, as the rice is cooked is actually called gelatinization. And when it cools down, it becomes a gel. And if it is cooled for a long period of time, then it actually then undergoes retrogradation. So therefore, retrogradation is just the process of when a gelatinized starch cools down. Okay? So, kumbaga, example ani no is bahaw, bahaw nga kanon. So, retrograded starch, okay, which is formed when starchy foods are cooked and then cooled. So, the long branch chains of amylopectin form double helices which cannot be hydrolyzed by digestive enzymes. Okay, remember that upon cooling, no, these crystals, these amylopectin crystals, will turn into some kind of shape or conformation that is no longer accessible by the enzymes. Okay, so of course, its occurrence is in retrograded starch, like cooked and then cooled starchy foods such as potatoes, rice, pasta, oatmeal, and stale bread. Or kung sa ato pa, kanang bahaw nato nga kanon. Okay? Next is RS4. So RS4 is a type of starch that resists enzymatic hydrolysis by modifying its original molecular structure and the addition of certain chemical functional groups by chemical modification. So this type of starch is usually made in the laboratory. So foods with chemically modified starches, maunang occurrence niya, no, such as cross-linked starch, which is usually modified no, in a lab. Okay, like it is also found in some commercially produced breads and pastries. Okay, the last type, and this is the most recent one, RS5. So it's a combination of long and unbranched starch chains with free fatty acids. So this is starch complexed with lipids. Okay, so it's very distinctive. Okay, because it's associated with lipids. Okay, so it is found in foods containing naturally occurring amylose lipid complexes. For example, bread containing fat as an ingredient, or foods which contain artificially produced amylose lipid complexes, and also a new non-viscous type of dietary fiber produced by the intentional rearrangement of starch molecules, which is called now your resistant maltodextrin. Okay, so this is actually the type of resistant starch that is formed no when you cook rice, and when you put like oil, or when you cook this rice, and then after you cool it down, then the caloric value of that rice is reduced. Maubay na ang maubay atong naa sa study no nga how to reduce calories to half of its normal caloric yield. So kato, while you cook or lungagod nimo ang rice, no, butangan nimo siya og oil, tapos kung maluto na siya, then i-refrigerate, then pagkaugma initon. So that's the method um nga pwede nato gamiton no to reduce the calories, and that is due to the formation of not just RS3, because if mag-cool down ning retrograde, if mag-retrograde no kaning gelatinized nga rice, so of course na RS3 nga ma-form diha, pero nagbutang biya ka og fat or oil during cooking. So after that process no, pwede na dayon siya produce kanang mga lipid molecules diha mag-rearrange, mag-associate with starch in such a way that they would form this now novel type of resistant starch, which is RS5. Okay. So, inana. So, why again is this being brought up? Because it's very important. This is again a type of fiber that has many physiological benefits, and it's helpful in a lot of health outcomes, like when you want to reduce the serum cholesterol levels, because it is fiber, and it's also very healthy to the gut microbiota, okay, because this is their substrate, this is a kind of prebiotic to them. And yeah, okay, so I think mao ni ang wala nato nataka last time no during our discussion. So next is we proceed to the proteins. Although I have already discussed about this one during our basic nutrition, but wala kayo na ko siya na-emphasize, no? So, and in this particular topic, no, we are going to delve more on its biochemical basis. Okay, so you know that PAM has actually three types. Now we have Marasmus kwashiorkor and Marasmic kwashiorkor. But first, let's discuss the two classic types of child protein energy malnutrition, which are Marasmus and kwashiorkor. Okay, so it's very important to know no, that these kinds of PAM are only occurring among children. Yeah, because the type of PEM that occurs in adults is different, no? Okay, so when you say child PEM, it usually refers to these three types of PEM, which are again Marasmus kwashiorkor and Marasmic kwashiorkor. Okay, so PEM is a disease on its own. Okay, so it manifests as a range of clinical syndromes. So therefore, it has signs and symptoms, just like what a disease is defined. So PEM, these types of PEM, no, could result from a dietary intake of protein and calories that is inadequate to meet the body needs. So let's distinguish these types of PEM, no, according to what a component of the diet is lacking. Okay. First, no, let's acquainted with the two protein compartments in the body. So we have the somatic and visceral. So somatic compartment is just composed of your skeletal muscles. Okay, so the muscles that surround your skeleton or the bones, maunang skeletal muscles na to. Okay, and this is usually the type of muscles that is sacrificed um, for their amino acids, no, so that these amino acids can be converted to glucose or can act as a source of energy when or during fasting, di ba? So that is the somatic compartment. The other one is called the visceral compartment, which is composed of protein stores in the visceral organs, primarily the liver. So the liver proteins are included, no, in the visceral compartment. Okay, so this includes albumin, okay, ferritin, okay, C-reactive protein, prealbumin, retinol binding protein. So all of the proteins that are hepatically synthesized are part of the visceral compartment. Okay, so why is this very important for us to be able to distinguish? Because the difference in between marasmus and kwashiorkor lies on knowing or lies on being able to distinguish, no, these two compartments. Okay, because the somatic compartment, no, is much more affected in marasmus, and then the visceral compartment is depleted more severely in kwashiorkor. So therefore, sa marasmus guys, mas wasted, no, or mas daghan ang protein loss sa somatic na compartment. So that means mas daghan nga proteins ang masacrifice sa skeletal muscles compared to the visceral compartment. Tapos sa kwashiorkor bali, mas daghan ang masacrifice, mas daghan ang mawala nga protein sa visceral compartment compared to the somatic compartment. And that is actually translated clinically, no, because the clinical features of marasmus and kwashiorkor, no, reflect on these losses. Okay. Okay. So this is these are pictures that would distinguish kwashiorkor from marasmus. So this one mauning ingon nato nga putot balat na lang, di ba? And we can tell that this is marasmus. Because what we know about marasmus is um it involves muscle wasting, di ba? in the somatic compartment. So as you can see here, wa na kaayo yung muscles, no, sa not just muscles, no, but also the subcutaneous fats are also sacrificed. Okay, so that's why a young appearance is skin and bones or butot balat, di ba? So the somatic compartment in here, as you can see, is manifested clinically, no? Makita nato yun nga na sacrifice yun ang somatic compartment. It's because wasted iyahang kamot, iyahang unsa ni kani iyahang clavicle deltoid nga part, which are skeletal muscles. Okay. And yeah, and again, not just ang somatic compartment, no, but also the subcutaneous fat. Okay. Whereas this one is a case of kwashiorkor. Okay. The main clinical distinguishing feature of kwashiorkor is that it's edematous. Okay. So naidima ang bata nga naay kwashiorkor compared to marasmus. That's why murag tan-awon na to ang kwashiorkor, murag mas dako siya, no, but dili na siya actually sa fat, patungod na siya sa tubig nga na-retain due to loss of visceral proteins, primarily albumin. Okay, the main function of albumin in the body is, aside from being a transporter of nutrients, it's also involved, no, in maintaining the right oncotic pressure between the fluid spaces or the fluid compartments of the body, such that if naay hypoalbuminemia or gamay ang albumin, then that would disturb the fluid balance, um, that would wreak havoc, no, on the balance between the fluid compartments, and that's why naay mahitabo nga edema or fluid retention. So di ba, it's also manifested clinically katong ato ang naibaw-an nga mas daghan ang masacrifice nga visceral compartment. It's because remember that albumin is a part of the visceral compartment, and you know that kwashiorkor must sacrifice ang visceral. So that's why mugamay ang albumin because it's a visceral protein, and makit-an gyud natong effect, no, nga niburot yun ang bata, nang hupong yun ang bata due to edema. Okay. So inana siya. So maunang maibaw-an yun nato, no, ma-distinguish yun nato right off the bat when we compare these two together. Makit-an yun natong differences because again si marasmus, it's skin and bones nga appearance, and then your kwashiorkor is edematous. Okay. So differences in changes in body protein compartments. Again, katong na-discuss na ko, somatic versus visceral. Anthropometric measures differ gyapon siya because si marasmus usually mag-lie siya diha, no, between -2 SD to -1 SD. Mao na siya usually ang anthropometric measures sa Marasmus. Okay, I know that you're done with this because na-discuss na ninyo sa assessment. Diba na atay mga standard deviations nga if ma-fall ang measurement sa negative nga SD, then mas underweight siya, mas wasted siya. Okay, so inana siya. And sa clinical features, na-edema si kwashiorkor, si marasmus wala. Okay. Yeah. Again, there's a third type of PEM, which is called marasmic kwashiorkor. Si marasmic kwashiorkor is usually would happen, no, when a marasmic child gets a very serious infection. Okay, that would complicate into marasmic kwashiorkor. So among the three, ang pinaka-severe, no, is marasmic kwashiorkor. Okay, then ang difference ani ni marasmic kwashiorkor For example, from kwashiorkor is that sa anthropometric measure. So si marasmic kwashiorkor is less than -3 SD. Ang iyahang weight for height as well as iyahang weight for age, okay, compared sa Marasmus. Okay? So, inana siya. And both of the clinical features of marasmus and kwashiorkor are seen in marasmic kwashiorkor. So, in marasmic kwashiorkor children na ang skin and bones appearance and naasad ang edema. So that's why combination of this kwashiorkor and marasmus would lead to marasmic kwashiorkor. Okay? Another distinguishing feature of kwashiorkor is that naa siya yung mga inani, no? Murag flaky paint nga appearance. Okay? And na irregular pigmentation. Makita nato kani nga side hypopigmentation. That means dili kaayo, wala kayo mga pigments. Then pag abot diri nga area na ay grabe na sad ka pigmented or grabe ka itom kumbaga sa ato. So if ang bata na inana, no, na ay kanang alternating bands of hypopigmentation and hyperpigmentation, then that is usually a case of kwashiorkor. And note that there is some kind of panghupong here na edema, no? Usually sa kwashiorkor patients, bilateral pitting edema is seen. That means both of the feet kay na ay edema. That's why it's called bilateral. Okay? And nganong pitting edema ang tawag, it's because kung i-pinch nimo siya, mulubong ra siya, and depende sa iyang level of severity. So kung mas dugay, mobalik sa original, mas dugay nga nakalubong siya or nakadepressed siya, so mas grabe ang edema. Okay? So this is not seen in marasmus. Okay? So maupod na another distinguishing feature of kwashiorkor. Okay, yes, kung ang marasmus, kwashiorkor, and marasmic kwashiorkor. So this one is definitely marasmus. Okay? Then another feature di ay sa marasmus is thinning of hair, just like what you can see here. Okay. Kaning sa tunga, this is kwashiorkor. Okay. Kinay ascites. Ascites is edema in the abdomen. Okay. So magbutod ang bata, no, and that is also fluid retention. Okay. So na ascites, bilateral pitting edema. Okay. And this one, this is marasmic kwashiorkor. Okay. So butot balat nga appearance, makita na to ang ribs, no? And na ay alternating bands of hyper and hypopigmentation and naasad edema. So both features of marasmus and kwashiorkor are seen in this case. So this is marasmic kwashiorkor. Okay. So by the way, I would just like wala na butang diri, no. Another difference is sa intake sa nutritional deficiency. Si kwashiorkor, it's just protein deficiency. So okay ang pwede nga okay ang calorie intake, okay iyahang carbohydrates, pero kulang ang protein. Okay, so usually kaning mga kwashiorkor cases naa sa mga regions nga ang diet is more on root crops, which is, you know, starch, or more on cereals like mga corn, di ba? Pero walay protein. Okay, like walay high quality protein. So if inana ang dietary intake, then that would lead to kwashiorkor. Pero if both proteins and carbohydrates and even fats are lacking in the diet, then that would lead to marasmus. So kaning marasmus usually may tabo ni siya during war, okay? Like mga emergency situations that would lead to total lack of calories. Okay? Then kaning marasmic kwashiorkor, if medyo magdugay no ang marasmus, then pwede siya mag-turn into marasmic kwashiorkor. So more on kumbaga kaning marasmic kwashiorkor nato mas dugay iyahang term compared sa marasmus. Okay, so inana ang difference sa dietary intake. Okay, so kwashiorkor proteins only na ang lack, and marasmus is total lack of food. Okay. So what is the treatment? What is our nutrition intervention for child with PEM? Okay. So actually all of these are acute ha. Acute need sila tanan. Okay. These are called severe acute malnutrition. Okay. So usually mas ma-encounter na to ang term nga SAM no sa real na nga setting, and some cases have manifest in this. Okay. Before we administer the appropriate intervention, we have to do the nutrition assessment first correctly. So anthropometry, of course, we measure the weight for height, okay, and the weight for age. Mauna. Pwede sad nato gamiton ang UWAC, okay. So if mundang ni guys, meaning kinahanglan di ay ko nga mag-upgrade di ay abi na ko kay unlimited ni siya. So later kung makat ni siya, I will just transfer no to another channel. Okay. Because Zoom akong gamit sa pag-record karon. So you will have like several videos no for this discussion. Okay, so treat this as the first part. Okay. Anyways, so mauto no, we measure those indices, and sige, excuse me. Ask kayo. Okay, so aside from those anthropometric measures, we also have clinical assessment specifically for identification of kwashiorkor noise. Again, if na bilateral pitting edema, so that's kwashiorkor. Okay, we would also look at the katong mga clinical features nga distinctive sa kwashiorkor, marasmus, and marasmic kwashiorkor. We also have appetite test and presence of complications. So this part would tell you no if the child with PEM is to be treated inpatient or outpatient. Okay, when you say inpatient treatment, naa sa sulod sa hospital, sa rehabilitation center or sa community hospital. Whereas outpatient, pwede nga ang treatment is sa balay or home management or home treatment. Okay? So, katong nag-fail sa appetite test, that means dili makakaon, no? So, kato sila, they must be brought to inpatient care. Okay? Pero katong nakapasa sa appetite test kay naarasad sila gana magkaon, then kato sila pwede ra outpatient. Okay? Yeah. So usually pares ni sila no. So if ang bata nga na IPEN nga ang bata nga na IPEM is okay ang appetite, tapos wala ra kayo yung mga complications, wala ra kayo yung mga serious infections, then usually they are treated at home or outpatient care. pero katong nag-fail sa appetite test and naay presence of complications and infections, then they must really be treated inpatient. Okay, so inana, I would as much as I would really like, to really specify, the procedure in treating child PEM kani siya sa community na ninyo nga subject, because this is actually like a a topic no under PMAM, or Philippine Integrated Management of Acute Malnutrition, which is a program in the community setting. So I'm just providing the overview no, of how this child PEM is assessed. And if kabalo na ta kung unsa siya, kung inpatient siya or outpatient, then or if naa siya SAM or MAM. SAM means severe acute malnutrition and MAM is moderate acute malnutrition. Then we provide na the intervention. So ang first line of intervention is water and electrolyte balance. So like all the other medical cases, unahon yun nato ang fluid and electrolyte balance before ta mag-worry sa caloric administration, because this is more life-threatening. So we have to correct any water deficits, kung na dehydration ang bata, ato sa na-correct. Then, ato pod atimanon no ang electrolytes, dapat normal, dapat walay hypokalemia ang bata, because usually mauna ang case sa naay PEM no, hypokalemic ang bata, kulang ang potassium, kulang ang sodium, so ato sa na-correct. Okay, so mauna ang first na itong abuhaton. Kaduha is diri na ang caloric administration. But to avoid the complication of refeeding syndrome, we must administer the calories ng at trophic rate. When you say trophic rate, less than 50% of the child's energy requirement. Okay? Nganong inana man, because again, to prevent refeeding syndrome. Refeeding syndrome happens when rapid administration of calories is done no, with a patient or with a child with PEM. Okay? So, mahitabuan na is na I'm insulin shoot up, and remember that the function of insulin is to stimulate the cells to absorb glucose from the plasma. Okay? So, ang mahitabuan na if na ay malnutrition ng bata and then itagaan mo siyang daghan nga pagkaon, okay, during refeeding, then kato insulin shoot up, and along sa entry sa glucose musulod pud ang daghan nga electrolytes, especially phosphate and potassium. So mahitabo mo deplete or mugamay ang electrolytes nga naa sa blood. So that would lead to hypophosphatemia for phosphorus, hypokalemia for potassium, and even hypomagnesemia for magnesium. So these are very important electrolytes when nga kung ma-deplete sila sa serum or ma-deplete sila sa plasma, ma-deplete sila sa dugo, then that would lead to many complications. So, yeah, so inana ang mahitabo sa lawas sa bata if nag-administer ka og daghan nga calories, no? Especially if malnourished sila. Okay? So ang sakto nga pag-administer sa calories is at trophic rate lang, then gradual na to increase. Okay? Dili nga insigidahon na to og hatag og 100% sa ilang calories, because ang mahitabo is refeeding syndrome. Okay? So the pan-up page no posted about the refeeding syndrome, no, so you can read more about that no dito sa katong PubMed. Okay, and inpatient treatment, usually ang form sa food nga ginahatag is not your regular food item, but your therapeutic milks, which are either F75 or F100. So F75 is 75 calories per 100 ml. F100 is 100 calories per 100 ml. So um, if ang bata is um, severe iyang malnutrition, and then ni-fail siya sa appetite test and naay mga daghan nga complications, then usually ang ginahatag is the formula that has lower caloric dose, and that is F75. Okay? Um, if na-accustom na ang bata sa F75, naamang yun ay phases guys sa treatment. So phase 1 F75 sa kay again trophic rate lagi dapat. Okay? Ang calories dili dako. Okay? Pagka second phase, maunang time no nga medyo naka-recover ng bata. So, i-transition na siya from F75 to F100. And then if naa na gyud ang bata to the road to recovery, then pwede na RUTF. RUTF is ready to use therapeutic food. So mauni ang sa SAM. But what about SAM nga inpatient? But what about SAM nga outpatient? Pwede sila tagaan og F100 or RUTF. Okay,